15-year-old girl presented to us with complaints of swelling of lower limbs for 4 months. Swelling was initially noticed at ankle and gradually progressed to knee, associated with excruciating pain and difficulty in walking. She also had associated significant history of poor weight loss of 10 kg during this course of illness, and also had dry and itchy skin. There was no other associated significant history. During this 4 months of course of her illness, she had 4 hospital admissions. In first hospital admission, she was treated as cellulitis with IV antibiotics for 7 days. After which patients had shifted their care to a private tertiary pediatric hospital. Investigation of leukopenia with elevated ESR, autoimmune workup, infective workup was negative. Venous Doppler showed no evidence of DVT. MRI of bilateral lower limbs showed non-specific pattern of multiple focal lesions in bilateral lower limbs, iliac bones and vertebrae, suggestive of possible sickle cell anemia. Hence, sickle cell anemia was ruled out with HB electrophoresis and sickling test. PET-CT done revealed generalized lymphadenopathy with minimal to mild metabolic activity and lytic sclerotic lesions in cervical dorsolumbar vertebrae and multiple upper and lower limb bones, edema in left lower limb, paravertebral soft tissue thickening or collection adjacent to lesions involving D7 to D12, L4 vertebrae and left sacral ala. At this point, child was advised to get further evaluation and workup with lymph node biopsy, but patient attenders deferred and shifted their care to another private pediatric hospital. Investigations done there showed improvement in leukocyte count, CRP was positive, ESR was elevated, HIV was negative, bone marrow examination showed features suggestive of osteonecrosis with no atypical cells seen, and tissue stain negative for AFB and fungal elements. Further, again, child was advised for further evaluation, but they did not pursue further. Meanwhile, child also developed lesions on left leg in lateral and posterior aspects with hyperpigmentation and thickening of skin, for which skin lesion biopsy was advised, which revealed necrotizing paniculitis with leukocytoclastic vasculitis. Bone marrow aspiration and biopsy were repeated, suggestive of scanty degenerated cells with necrotic bony spicules, suggestive of suspected polyarthritis nodosa or other autoimmune workup. Here, the child was advised to further evaluation with connective tissue disorders workup, but they did not pursue. And further, they got PET-CT done and got discharged. PET-CT done showed progressive disease. At this point, they presented to SRMC. The other history was not significant. Weight was below 3rd centile, height was between 10th to 25th centile. On local examination, there was diffuse swelling on left lower limb till mid-thigh. Hyperpigmented lesions present over posterolateral aspect of left lower limb, and skin thickening and edema was present. Systemic examination was unremarkable. With the clinical features of swollen legs, excruciating pain, significant weight loss, skin lesions, and generalized lymphadenopathy, and investigations showing osteonecrosis, lytic lesions, and generalized lymphadenopathy, and infective autoimmune and hematological disorders workup being negative, a strong suspicion of malignancy was considered in spite of histopathology being inconsistent. A multidisciplinary team meeting involving hemato-oncology, pediatric rheumatology, infectious diseases, radiology, pathology, and dermatology was conducted, and following possibilities and further plan of action was discussed, and she was evaluated accordingly. This is the evaluation done in SRMC, where the repeated count showed leukopenia with elevated ESR. Other workup was negative. Outside blocks were reviewed again and was opened as features suggestive of T-cell lymphoma. This is a bone marrow examination slide showing bony trabeculae enclosing necrotic bone marrow. The slides were sent for second review, where IHC was repeated and the markers were positive for high-grade T-cell lymphoma. T-cell clonality analysis was positive, suggestive of T-cell lymphoma. These are the histopathology slides showing positive for CD8 and CD4 markers. During the course in illness, during the course in hospital, the case details were discussed with experts and was planned to start therapy as T-cell ALL. Family was counseling in detail regarding the diagnosis, treatment options, and prognosis. PICC line was inserted, and during the PICC line insertion only repeated bone marrow examination was done, which revealed bone marrow necrosis. It started on ALL TNHL therapy and is currently on induction phase week 3. Child has clinically improved and currently she is doing well. Discussion. So because of the time limit, we are concentrating only on osteonecrosis part here. So coming to osteonecrosis, it is collapse of bone due to temporary or permanent interruption in the flow of blood to the affected bone. These are the risk factors, namely drugs, autoimmune, malignancy, hematological disorders like sickle cell, thrombophilia, infections like HIV, storage disorders, and less likely chronic nephropathy and post-transplant status. Multifocal necrosis is defined as osteonecrosis involving 3 or more distinct anatomical sites concurrently. It is a rare clinical condition reported in approximately 3% of osteonecrosis patients. This is a case report showing juvenile onset multifocal osteonecrosis in an SLE patient. Coming to pathophysiology, combined effects of genetic predisposition, metabolic and other local factors can cause vascular injury and increased intraosseous pressure, thereby affecting blood flow both in the bone and also the adjacent areas of bone. This is usually followed by reactive angiogenesis characterized by sinusoidal congestion. However, sometimes the angiogenesis is impaired, resulting in demineralization and osteonecrosis of bone. Bone marrow necrosis and osteonecrosis etiology and pathophysiology is almost the same. Bone marrow necrosis is associated with malignancy, seen in 90% of those reported to have bone marrow necrosis. Of this, hematological malignancies account for 60%, of which ALL accounts for 80% of hematological malignancies, followed by non-Hodgkin's lymphoma, and the association of bone marrow necrosis with solid malignancies is less consistent. Coming to osteonecrosis in cancer survivors, it is very common and it causes significant long-term toxicity that can compromise joint functionality and quality of life in afflicted survivors of childhood. And the incidence is 2 to 10% of children treated for ALL. It remains asymptomatic or associated with only minimal non-specific symptoms until it becomes advanced. The prognosis relevance of bone marrow necrosis in patients with malignancy remains unclear. But seeing the studies on AML and ALL, bone marrow necrosis at initial diagnosis had lower complication and survival compared with patients without bone marrow necrosis. However, we don't have clear details regarding pediatric patients. So, coming to the conclusion, it is always important to rule out neoplastic process when osteonecrosis or bone marrow necrosis is encountered, after ruling out common causes like sickle cell disease and autoimmune pathology when clinically warranted, even if histopathology is inconsistent.